Thank you, James. Good morning, everyone. I will try my best to tell you what Suzanne was hoping to tell you about training in oncologic pathology this morning. She doesn't have anything to disclose, but I will disclose that I made a few minor tweaks to her slides at the back. I may not be quoting her exactly, so I'll accept any responsibility for that. All right, so back in 2013, we had a landmark workforce summit. I would say landmark because this summit really brought together a lot of our societies. We had about 24 society representatives together. It was organized by the College of American Pathologists and co-sponsored by the American Board of Pathology and many of our larger organizations for pathology, such as the ASCP, the Association of Pathology Chairs was there, and the United States and Canadian Academy of Pathology. Several statements were issued as a result of the summit that was really convened to see where are we with the workforce in pathology, because there had been data to suggest that we're going to face a severe shortage of pathologists in the future, and that there may also be concerns with the supply chain. So we looked at all of that, and as a result of the work done for the summit, a number of statements were issued to provide, in an effort to decide how to provide education and training to meet the future of pathology. So what needed to be added? Molecular diagnostics and population medicine rose to the top. Emphasis much more so on laboratory management and quality improvement practices. But how and when to do all of this? How much education was needed? What could we remove? Because obviously we can't keep adding to things to training when actually in 2002 we decreased pathology training, which used to be 5 years, and prevented a lot of people from going into the specialty because of its length. We made it 4 years, and now we're talking about the need to add a lot more practice areas into pathology. Action items that came out of this was that we needed more resources for some of the new areas in pathology, especially around molecular diagnostics, genomics, and informatics, which have already, I'm pleased to say, been developed for residency and fellowship training. And the second was to develop a survey that has been deployed for 4 years in a row now to graduates new in practice, 10 years or less, to see how they've felt that their training in residency prepared them for their practices, both academic as well as private practice. Now, just to take a step back, the pathology residency at this time, as I mentioned, is 4 years. The majority of our trainees do anatomic and clinical pathology, AP and CP, and oncologic pathology is seen in areas of anatomic and clinical pathology. And to tell you the truth, the lines between these, which used to be sharp and delineated in the past, are much more blurry now because, for example, informatics, management, and molecular diagnostics span through these subspecialty areas, and that transition is not as sharp anymore. But as far as oncologic pathology is concerned, surgical pathology, hematopathology for lymphoma, leukemia, as well as the minimally invasive techniques employed by cytopathology are important. And autopsy pathology, as Dr. Cohen mentioned earlier, still remains a very important quality assurance measure for cancer outcomes. The residency fellowship training, as the radiology folks are also aware, is governed now by looking at 6 competencies that are that were put forward by the Accreditation Council for Graduate Medical Education, but also by supported by the American Board of Medical Specialties, and are now used for the Joint Commission's ongoing professional practice evaluation of pathologists and physicians in practice. And these comprise patient care, medical knowledge, practice-based learning and improvement, interpersonal communication skills, professionalism, and systems-based practice. And residents and fellows have a semi-annual milestone reporting that looks at their progress through their training in these competencies. So in oncologic pathology specifically, for resected cases, there's utilization of standardized synoptic reportings that is based on the American Joint Cancer Commission's staging parameters. And these templates are and should be utilized nationwide and also often internationally. There are also increasing usage of minimally invasive cytologic techniques, fine needle aspiration, etc., for diagnosis, prognosis, and therapeutic decision-making for stage 4 advanced disease, which for the most part doesn't go to resection unless that is needed for symptomatic relief. Hematologic malignancies are a whole league of their own with a lot of correlation with ancillary studies. Screening for cancer prevention with the PAP test, as mentioned earlier, and now with HPV testing, hemoccult for colon cancer screening is also part of oncologic pathology, cancer screening and prevention. But key to all of these endeavors now is the correlation with ancillary studies, be it next generation sequencing, immunohistochemistry, FISH, flow, or cytogenetics. And as you're aware, there are a lot of companion diagnostics now that have targeted drugs associated with them. So tumor staging reporting on surgical resected specimens is a very important parameter in oncologic pathology. And we're now in the 8th edition of the staging manual by the AJCC. And all these organ systems are reporting templates are developed by experts in the area. And the tumor registries collect organ-specific data based off of these reports that should be complete, including laterality, procedure, the grade of the tumor, and then the TNM staging, and be presented in a synoptic format. This is a website image from the College of American Pathologists that highly encourages the use of these templates, especially starting earlier this year for the new 8th edition, and they're freely available for use from all practice settings. Here's an example of a carcinoma of the colon rectum, and this is what a synoptic report should look like. So there's a lot of details here that are very important to the patient management and prognosis that can be gleaned from this. And using complete reports like this is imperative to passing on and communicating to the physician how the patient should be managed. Here, on the contrary, is an example of an incomplete report. It still tells you that the patient has an invasive adenocarcinoma and its size, and tells you about its margins and lymphatic invasion and metastatic tumor, but it's not acceptable in this day and age because it doesn't have all the elements that are necessary for complete reporting and cancer staging. The cytologic technique has now become more and more utilized, as I said, in advanced disease and cancer screening. We perform fine needle aspiration, adequacy and triage in interventional radiology, often to make sure that we get enough material, the right material, and send it for the right additional testing. Body cavity fluids are important in the follow-up and metastatic staging, etc., of patients and their relapses. And a lot of this cytologic material can be used for next generation sequencing because we can do a lot with very little now. And these are non-invasive in and out techniques that don't need anything more than a mild local anesthetic and in and out procedures. So in our residency fellowship programs right now, during residency, the utilization of templates and standardized reporting is common and utilized in both academic centers as well as private practice settings that residents and trainees may rotate through. And the reporting utilizes many different lab information systems. So as many of you may or may not be aware, most hospitals still have their own lab information system that integrates with the clinical electronic medical record, and those transitions of reports need to be seamless to allow for information to be disseminated quickly, easily, and accurately. Graduated responsibility during residency is something that we all struggle with, especially in areas that are certified by boards, because you cannot have independent sign-out capabilities. But as residents and fellows progress through their training, they do get the opportunity to preview their slides, draft reports and diagnoses. Some places have a hot seat in the frozen section suite so that there is help available immediately, but the final sign-out of the on the dotted line is not allowed by a trainee unless they're in a non-ACGME accredited training program and have hospital privileges. A new concept of entrustable professional activities has emerged that I'm going to talk a little bit about when I do my next talk, so I won't address it right now, but that is something that will allow for a much more personalized graduated responsibility, both for medical students as well as trainees in their residency and fellowship. Now, communication of results is critical, and whether it be done written or verbally, it needs to be in a format that is standardized and communicates consistently the essential elements that need to be communicated. Preliminary reports can be dangerous if they make their way into notes in the electronic medical record. I'm sure the radiologists have seen this too. So personally, I don't like giving preliminary. We do it in a teaching hospital for teaching purposes, but I don't put out anything preliminary because it has a way of then not getting integrated into the final. So there must be clear distinction between what's preliminary and what's final. Unexpected findings and reporting of these findings is essential for both our specialties, and the documentation of when this was done, to whom it was done, is also an essential component that most of us include in the body of our reports. The challenge, though, can be finding the right person to give that report to. And there was the gentleman in the earlier session asked a question about what we can do right now. And what we've done at Northwestern, where I'm from, is we've created actually a call center that is manned by nurses 24/7 that helps connect the radiologists and laboratory and pathology medicine for both our clinical pathology as well as anatomic pathology results. When we're not successful in reaching a physician, they actually help us make that contact, and that saves a lot of time, effort, and also prevents things from falling through the cracks. And we can make sure that those who need to know that result get to know it. There's also an important difference between amended reports and addendums. An amended report in the pathology world is one that has an impact on patient management. So there's a change in the final diagnosis or a modification in it that is significant, whereas an addendum may be something like reporting stains on a granulomatous lymph node that are negative for mycobacteria and fungus. That can be an addendum because it doesn't change your initial diagnosis. So we educate our residents and fellows through simulations and real daily work with constructive feedback on how to word their reports and how to communicate verbally also, and to keep in mind all of these elements that can lead to communication gaps and hence errors in the system. Our leading pathology organizations have also emphasized the importance of timely secondary reviews for malignant cases to improve patient care. And most pathologists, when it's a first-time diagnosis of malignancy, will have a second pathologist look at it. Difficult, unusual cases get group consultations. And we document all of this again, that this was seen by a group or more than one pathologist. This is good practice. And also, we have a lot of emphasis that's been placed in, again, from our leading organizations on good communication and decreasing error by keeping in mind quality assurance activities and passing these on to our trainees. We do a lot of quality in pathology, of course, at the back end, and root cause analysis is something that our residence fellows have the opportunity to be involved in. We encourage liberal reporting of errors and then root cause analysis to see why the error occurred and how we can prevent that error in the future. And as many of you are aware, these errors many times are not related to the diagnostic area of pathology or radiology, but actually occur at the pre-analytic or post-analytic level. So we try to cover all of these as we go through our training in oncologic and non-oncologic pathology. There's also expert consultation. Real-time tools are now available. We have telepathology that many institutions use both within the system as well as for expert consultation outside the system. Whole slide imaging is there. It's still not in use real time in most institutions. We'll be hearing more about that from the UPMC perspective later in this conference, but these tools have started making their way into pathology but are not mainstream yet. They do, however, provide the opportunity for easier and more rapid consultation with the experts. Training our residents and fellows depends heavily on their interpersonal and communication skills, both when they're communicating intraoperatively and in their final reports. This is a recent publication that appeared out of the Toronto Health Network, where there's a large hospital system, and they've developed a high-quality integrated informatics system to enable consultation across the spectrum of their hospitals. And this is what ultimately will need to happen with personalized and precision medicine as things become more and more complex. So right now, the continuum between academic practice and community practice is beyond real time, and referral patterns and development of consultation networks for subspecialty support are available and should be utilized. Incorporation of exposure to multidisciplinary tumor conferences is mainstream in all training programs in pathology, and our trainees actively present the cases and interact with radiology, oncologists, and other caregivers at these multidisciplinary conferences. Diagnostic accuracy in cancer care is emphasized both at the department, hospital, and institutional level. And many institutions actually have requirements for secondary review when a new diagnosis of cancer is rendered, and also to look at a second opinion when there's outside pathology for patients who are being seen in the system for the first time. Quality management and improvement are part and parcel of everyday practice of pathology. Their monthly conferences, or even more often, to review cancer cases and their reports for completeness and accuracy. Our accreditation requirements focus on a lot of these aspects also, so it's something that we're used to doing on a daily basis. And the residence fellows are actively involved in these sessions. They might include actual glass slides, telepathology, frozen section, cytology, histology correlation. So there's a lot that they learn from these daily QA and QM activities. Pathologists also serve on several hospital committees, including cancer committees, tumor registry. As I mentioned, they utilize our pathology reports, which makes it very important for us to use standardized reporting templates and issue complete reports. And right now, all that I've talked to you about can be done in community practice as well as academic practice when our trainees graduate. So in summary, training in oncologic pathology requires that we teach reporting standards. Our report should be complete and accurate, that we teach good verbal written communication that is clear, timely, and concise. That we participate in multidisciplinary conferences. This is critical to good patient care. Integration of ancillary studies and companion diagnostics is crucial in this era of personalized medicine, and smaller programs where a lot of this ancillary testing is sent out, as was mentioned earlier, there needs to be an extra level of effort to get those outside reports and teach the residents about how it all comes together if it's not happening in your own system. So quality management activities are important because they help reduce error that can significantly benefit from these activities. So currently, we aim to prepare our trainees similarly for both community and academic pathology practice. The question remains, should this be the future state, or does this training need to change? Thank you very much.